Welcome to this explainer. Today, we're diving straight into the clinical pathway of bone infections. It's a fascinating, high-yield journey where we're going to cover everything from diagnosing incredibly deceptive cases of osteomyelitis to the high-stakes decision-making behind complex limb amputations. There's a ton of critical information to unpack here, so let's get right into it. Here is our roadmap for today. We're going to cover diagnosing deceptive bone infections, identifying the usual suspects, targeted antibiotic strategies, and finally, surgical amputation techniques. Let's jump in. Section 1. Diagnosing deceptive bone infections, the diagnostic illusion. Imagine an 8-year-old child comes in, they've got severe tibia pain, a high fever, chills, and they absolutely cannot walk. The clock is ticking fast here. So what's the correct, immediate approach to this acute presentation? First off, you've got to realize that pediatric presentations can be incredibly subtle. Sometimes it just looks like pseudo-paralysis, where they just don't want to move the limb. You cannot wait around for definitive culture results. The absolutely crucial point here is that you must draw blood cultures immediately and then hit them with empirical, broad-spectrum IV antibiotics right away. Any delay, well, that mandates urgent surgical decompression and debridement to stop ischemic cortical necrosis in its tracks. Now, let's bust a major clinical myth. MRI, that is your absolute gold standard. It's incredibly sensitive to early marrow edema. On the flip side, CT scans and plain X-rays are notoriously insensitive. They can look completely normal in the early phases of infection. To put that into perspective, burn this number into your brain. 7 to 10. That is the 7 to 10 day X-ray rule. A plain X-ray will actually stay entirely normal for up to 7 to 10 days into a nasty acute bone infection. Lytic changes won't even show up until practically 30 to 50% of the bone mineral is already totally destroyed. So if you're waiting for an X-ray to confirm the infection, you've waited way too long. This leads right into our biopsy strategy, and you've got to watch out for some major pitfalls here. If your patient is already on antibiotics, it suppresses the bacterial load, which gives you false negative tissue cultures. And I really can't stress this enough. Superficial swabs are practically useless. They literally only pick up everyday skin bacteria, not the deep pathogen causing the real damage. To get it right, you strictly need multiple, independent deep tissue or bone biopsies. Section 2, identifying the usual suspects, the microscopic culprits. All right, once we have those deep biopsies, who exactly are we hunting? Here's a pivotal question for you. Which highly virulent pathogen is the most common overall cause of both bone and joint infections, meaning both osteomyelitis and septic arthritis across all age groups? It's Staphylococcus aureus, and there's a fascinating biological reason for its absolute dominance. It doesn't just accidentally end up in the bone. It actually has specific surface receptors, known as adhesins, that bind directly to bone matrix components. It is literally custom-built to infect the skeleton. But, medicine is all about the exceptions to the rule, right? While Staph aureus rules native bone, things shift depending on the patient. If they have sickle cell disease, the classic culprit shifts to Salmonella paratyphi. If you introduce orthopedic hardware like joint prostheses, you're suddenly dealing with low-virulent, slime-producing biofilm bugs like Staphylococcus epidermidis and Cutibacterium acnes. And if there's an insidious infection in the spine, classic Pott's disease, you're looking at Mycobacterium tuberculosis. Sometimes, though, the body fights back in a really specific way, creating what we call a Brodie's abscess. This is a localized subacute or chronic osteomyelitis. What happens here is pretty wild. The host's immune system successfully traps the Staph aureus inside a radiolucent space, totally encasing it in a thick, sclerotic wall of reactive bone. Systemic antibiotics really struggle to break through that wall, so you almost always need to go in for surgical curettage. And this perfectly highlights the difference between a Brodie's abscess and another name you might hear on exams, Guérin's sclerosing osteomyelitis. Brodie's is that radiolucent nidus in the metaphyseal region that needs curettage. Guérin's, on the other hand, is marked by massive periosteal new bone that severely thickens the cortex, and it classically targets the mandible. Keep those two clearly separated in your mind. Section 3. Targeted antibiotic strategies, the medical arsenal. So, how do we actually deploy our meds to fight these bugs? Let's look at another case. What's the recommended empirical antibiotic therapy for community-acquired osteomyelitis in a 12-year-old child who doesn't have any specific risk factors for resistant pathogens? Well, the guidelines point us straight to coamoxiclav. That's amoxicillin mixed with clavulanic acid. It's our absolute first-line defense. It perfectly targets the standard gram-positive cocci, like penicillinase-producing Staph aureus, but it also provides solid empirical coverage against the respiratory rods we often see in pediatric cases. But of course, we need an escalation plan for when things get complicated. We start with that base of coamoxiclav. If there is an MRSA risk from a hospital stay or instrumentation, we immediately escalate to vancomycin or teicoplanin. And if the infection comes from something like a puncture wound through a sneaker or an open fracture, we've got to add Pseudomonas coverage, pulling out the big guns like meropenem or ceftazidime. Section 4, Surgical Amputation Techniques, the climax. Unfortunately, sometimes medical management fails, or the tissue destruction is just too massive. Consider this really severe scenario. A 49-year-old female presents with wet-on-dry gangrene involving her entire foot. What is the optimal surgical management when it's this advanced? In a case like this, the optimal solution is a transtibial or below-knee amputation, specifically utilizing a long posterior skew flap. The goal here is a really delicate balancing act. You have to totally eradicate the dead, infected tissue, but you also have to preserve a stump that's actually going to give the patient long-term functional mobility with a prosthesis. Now check out the surgical mechanics here. The traditional Burgess flap puts the transverse closure right over the sharp anterior bony stump of the tibia. That drastically increases the risk of the wound splitting open from tension. But the skew flap modification, it brilliantly rotates those incision lines to clear that prominent bony edge, which seriously reduces the tension. When you're building these flaps, geometry is literally everything. Look at this number, 1.5. The vertical length of the posterior myocutaneous flap has to be exactly 1.5 times the length of the anterior incision. This magic ratio guarantees you have enough tissue for a tension-free closure and plenty of padding over the cut bone. To build that highly functional stump, surgeons follow some strict anatomical rules. The anterior incision sits about 12 centimeters, roughly a handbreadth, below the tibial tuberosity. The length of that cut should match about 1/3 of the calf's circumference, so you don't get those redundant, overlapping pockets of tissue known as dog ears. And finally, confirming a palpable pulse just above the cut drops the risk of the stump failing from ischemia to near zero. Which brings us to one final, really crucial question to chew on. With all these complex cuts and major interventions, why is preserving an intact knee joint the absolute highest priority in lower limb amputations? Well, it's because keeping that knee drastically decreases the metabolic energy it takes for the patient to ever walk again with a prosthesis. It's the literal difference between navigating the world efficiently or facing an exhausting uphill battle with every single step. Thank you for joining me for this explainer. Keep these clinical pearls in your back pocket and never stop questioning the deceptive nature of disease.